Good afternoon, everybody. It's top of the hour, so we're going to get started. Thanks for joining the first webinar in the Colorado Cancer Coalition webinar series. I'm Ian Kahn. I'm the co-chair of the Colorectal Cancer Task Force, along with Meg Phillips. We will be recording this session, just so you know, and it will be available at some point afterwards. Everyone right now is on mute. We'll ask you to come off mute at the end of the presentation for questions. And then I just have a couple of announcements here. As you can see on your screen, there are some resources that will supplement what Dr. Patel talks about today from Fight CRC. And then also the University of Colorado, Fight CRC, and a host of international experts convened a meeting to study causation and early age onset disease in February. The meeting summary with study plans was published in the August issue of Gastroenterology, which is a leading journal. They're super excited for it, and we're proud to have this work going on in Colorado. It's really, really awesome. So Dennis Onen is featured on the video that's linked here, and Andy Dwyer was actually our lead author on the paper, and with the expanding work group, who has now emerged to study early age onset disease. So again, I've also posted these links in the chat boxes, so you can take a look there. And without further ado, we'll go on to our headliner today. So we're going to hear from Dr. Swati Patel. Dr. Patel completed her master's in Health Systems Administration from Union University and attended Albany Medical College for her medical degree. She completed her internal medicine residency and gastroenterology fellowship at the University of Colorado. She is board certified in internal medicine and gastroenterology and was on faculty at the University of Michigan, Go Blue, from 2013 to 15 and joined CU in 2015. She is the director of gastrointestinal cancer risk and prevention clinic at Anschutz Medical Center, where she cares for patients at high risk for cancer based on their family history and genetics. Her clinical and research interests are in colorectal cancer prevention, identification, and management of patients at high risk for colorectal cancer, and colonoscopy quality and training. So with that, I guess I could have showed you that slide. I will stop my share and we'll turn it over to Dr. Patel, and I'll put myself on mute.
Great. Thank you so much, Ian, for that introduction. It's really a great honor to be able to present during this webinar. I really appreciate the invitation. So I've been asked to really frame the issue of early age onset colorectal cancer and really lead into some of the recent discussions on whether we should be considering a different approach to how we've been thinking about colon cancer screening in our patients. And so really what I'd like to do today is talk about how the epidemiology of colon cancer is changing, in particular in respect to patients under the age of 50. We'll talk about the clinical and pathologic features of patients diagnosed with colon cancer under the age of 50 and how that contrasts with older patients. We'll discuss the risk factors that have been proposed for this rise in colon cancer that we're seeing in young folks, as well as the potential contributors to this rise. And then really spend some time talking about the practical kind of boots on the ground opportunities we have to approach this rising incidence in mortality. And then kind of wrap up by reviewing how all of this sort of leads to our approach to screening and guidelines. So, you know, it's really no news to this audience, and certainly the lay press has certainly given this issue a lot of attention, that there really has been a steady increase in the incidence and mortality associated with colon cancer in young patients, and really alarm associated with this with patients that we generally would never expect to develop colon cancer being at risk for this disease. And so what we know is that fortunately, in large part due to effective screening measures in this country, we've seen a steady decline in the incidence of colon cancer in all patients over the age of 50, however, have seen a rise in the incidence in every decade under the age of 50. We know that this trend has taken place really across the country, but there might be some differential sort of impact depending on the region of the country. And though the mountain states should seem to have a lower incidence than the South and Appalachia, there's still been an increase, and in particular, specifically in Colorado, as you can see, there's been a decrease in the incidence associated with colon cancer in patients over the age of 50. However, an increase, as the red line shows, in patients under the age of 50. What's interesting is that really we're really observing this as what's called a cohort effect, meaning that patients born, 20-year-olds born in the 1940s and 50s seem to have a substantially lower risk than 20-year-olds who were born in the 70s and 80s, suggesting that there's something different about the potential exposures that this generation of patients have compared to older generations. So we know that it is the second most common cancer in patients under the age of 50 and the third leading cause of cancer-related death. There's been a 51% increase in the incidence of colorectal cancer in young patients and about an 11% increase in mortality associated with disease in these young patients. We know that African Americans are disproportionately affected compared to non-Hispanic whites. And at this point, even though overall all cancers, really 10% occur in patients under the age of 50, we know that in African Americans, actually 16% occur under the age of 50 compared to 9% of non-Hispanic whites. And so really kind of a proportional shift for our African American patients. These patients have a higher mortality when compared to other ethnic groups and have a worse 5-year survival. Most of these cases occur in patients between the ages of 40 and 49. And we know that really the proportion of cases will continue to increase for those under the age of 50, such that even between 1990 to 2013, the proportion of cases under the age of 50 for rectal cancer increased in patients under the age of 55 from about 15% to now 30%. So how does this disease present? What are the clinical and pathologic features? Well, what's interesting is that the vast majority of patients under the age of 50 present with some type of symptom, and we'll talk about that a little bit. And unfortunately, there's a significant delay between the time of symptom onset to the time of diagnosis, with patients younger than the age of 50 having to wait up to 217 days compared to those over the age of 50, which oftentimes are diagnosed under a month. As we would expect, younger patients tend to have a family history of cancer, more so compared to later age onset patients. And what's really kind of developing as a very interesting feature of this disease in young patients is that it tends to occur much more commonly in the left colon, and in particular in the rectum compared to older patients. Younger patients are more likely to have multiple cancers, whether it be synchronous or at the same time or separated in time. And unfortunately, they have much more aggressive histologic features and are more likely to be diagnosed at more advanced stage compared to older patients. This trend is also borne out when we look at our patients here in Colorado, where again, these patients are much more likely in the red bars to be diagnosed at a later stage of disease compared to older patients, and also have left-sided dominant disease compared to the older cohort of patients diagnosed with cancer in our state. So what do we know about the risk factors to this rise of early onset colon cancer? When we take all comers, we know that for patients diagnosed with colon cancer under the age of 50, approximately 16% have some hereditary or genetic predisposition to cancer risk. And so really that leaves 84% that have no associated or identifiable hereditary syndrome or genetic mutation that we can attribute their colon cancer to. However, what we do understand is that probably about 25% of these colon cancers are associated with at least a family history and are considered familial risk. And so really, the risk of colon cancer with respect to family history has really been very well established. We know that if a patient has a single first-degree relative with cancer, regardless of the age of diagnosis, that family member has an over twofold risk of developing colon cancer. If that first-degree relative was diagnosed at a young age or under the age of 50, that risk is over a fourfold increase compared to the general population. And as you can see, the more relatives that are affected within the family, the higher the risk of colon cancer. But what about all these other patients that don't necessarily have a family history, that don't necessarily have a genetic mutation? Well, just as we see the rise in colon cancer as demonstrated in this graph in patients under the age of 50, there's also been an increase in uptake of colonoscopy. So is it possible that we're just diagnosing more of these patients because colonoscopy is more available to patients under the age of 50? Although these kind of curves sort of mirror one another, and it's a reasonable thought, this really is unlikely to be a good explanation for the rise in early onset colon cancer because, as I've mentioned, these patients tend to present at later stages of disease, have more aggressive tumors, and so that really wouldn't be explained by just diagnosing these patients earlier with use of colonoscopy. What about how our lifestyles and our exposures have changed over time? Well, we know that there are certain established risk factors for colon cancer in the general population, such that certainly high waist circumference or elevated BMI, excessive alcohol use, red meats, processed meats, smoking, we know increased risk of colon cancer in our patients. And we know that there are certain protective factors such as physical activity and fiber. So is it possible that really kind of changes in our society in terms of sedentary lifestyles, increase in consumption of some of these kind of food items may be contributing to that rise? It's certainly a possibility, though the data really looking at specifically early age onset patients at this point is still limited. But when we look at the graphs of this rise in colon cancer in patients aged 20 to 49, it certainly kind of mirrors what we see in obesity and kind of extreme obesity in our country over the last several decades as well. But really, there are multiple hypothesized risk factors for early age onset colon cancer, and this rise that we're seeing, differences in our exposures that have been hypothesized, including, of course, obesity and diabetes or metabolic syndrome, but also certain novel risk factors such as exposures early in childhood that may change the microbiome of the colon, such as childhood antibiotics, antibiotics in the food chain, industrialization of our food industry, increase in sort of inflammation and atopic conditions, potentially ambient radiation exposure, as well as regional environmental exposures, especially as we see regional differences in incidence in our country. But, with that said, although we don't fully understand the etiology to this rise in early onset colon cancer, what can we do to actually kind of manage this rising incidence and decrease the burden of cancer in our society? Well, some would say, why is this important to do? Because certainly, although we've seen a rise in early age onset disease, if you draw your attention to the y-axis of these graphs, you can see that though the slopes of the graph are opposite, that there is indeed an increase in incidence and mortality in young patients, really the x or the y-axis really indicates that the magnitude is significantly different in patients under the age of 50, where we're talking about an incidence increasing from about 10 in 100,000 to maybe 14 in 100,000, relative to patients in the 50 to 65 year range, where we're talking about incidence rates, although improved, but still in the 200 per 100,000 population. And so some would say, is the burden of disease really substantial enough for us to address this rise? And I'd like to make the argument that it is, but really put another way, when we look at this disease burden, patients diagnosed under the age of 50 comprise approximately 10% or so of all colon cancers diagnosed in our society. But really thinking about the burden of this disease, what's interesting is that the person years of life lost for patients diagnosed between the age of 45 to 49 is very nearly approaching the person years of life lost for patients diagnosed between the age of 65 to 69. You can start to capture why that may be. Individuals in their 40s and younger are significant contributors to society, are caretakers of their family members and even elderly members of the family. So what can we do to address this rise in early onset colorectal cancer? Certainly, there's a strong emphasis to take symptoms seriously. We know that symptoms are oftentimes the most common presentation to colon cancer in young patients, and that there's unfortunately a significant delay between symptom onset and diagnosis in these younger patients. There's also an extremely important effort to continue improving recognition of patients with very high risk and those with hereditary syndromes, as well as improving initiating earlier screening in high-risk patients based on family history of both colon cancer, advanced adenomas, and then certain ethnic groups that we know harbor increased risk. And then really to consider whether it's an appropriate path to start considering screening all individuals, regardless of their risk profile, earlier. So we'll review all of these in brief detail here. And so what's interesting is that the most common symptom that patients diagnosed with colon cancer under the age of 50 have is bleeding. Bleeding is a common symptom and oftentimes can be attributed to benign disease such as hemorrhoids or fissures. But the symptoms of bleeding really are difficult to draw any conclusive diagnosis on without really further evaluation. And this is borne out by studies that have been done. This was a study with about 220 patients that presented to their primary care doctors with bleeding, young patients. And actually 10 to 12% of these patients either had a precancerous colon polyp or a colon cancer. And what really is humbling for clinicians is that our clinical sort of decision-making using history and physical examination really just isn't reliable enough to exclude more serious pathology. And so really in a study of patients that presented with scant bleeding, in approximately 20% of these patients where the primary care doctor really was confident that the source was something benign, such as a fissure or a hemorrhoid, 17.5% of these patients actually had a higher rectal source or colonic source of the bleeding. And so it really emphasizes that we cannot rely on our history and clinical bedside examination to exclude more serious pathology. And certainly the presence of hemorrhoids doesn't exclude something more serious, more proximal in the colon, whether it be in the rectum or higher up. And so it's really important for us to kind of spread the message to take symptoms seriously, regardless of the age of the patient, that if you don't have a clear explanation for bleeding, unintentional weight loss, changes in bowel patterns, abdominal pain, that should be further evaluated, likely with an endoscopic examination. And although this delay that we see in diagnosis is multifactorial, that certainly patients under the age of 50 may not see a primary care doctor consistently enough or may not seek medical care, and that may contribute to delay. It's extremely important that as providers, we educate our communities, our colleagues, that we really need to do the best that we can to minimize contributions to this delay by dismissing symptoms, delaying evaluation. So another kind of very important avenue to address this rise in early onset cancer is to continue efforts at recognition of hereditary syndromes. We all know that these hereditary syndromes, such as Lynch syndrome, the polyposis syndromes, significantly increase risk of colon cancer as well as other cancers. But unfortunately, they're grossly under-recognized. This was a modeling study that was published back in 2011 that estimated that less than 2% of Lynch syndrome mutation carriers were even aware of their diagnosis. in the United States. And although we're likely doing better than this now, I think we're still grossly under-recognizing these hereditary syndrome patients. And so it's important within our systems of practice to improve recognition, but you can understand why this is a challenge for clinicians. Certainly, acquiring and acting upon multi-generation cancer family history is very, very challenging. But even in patients who are diagnosed with cancer, there are so many critical pieces in the care of that patient, and certainly the primary care doctor, the endoscopist, the surgeon. We're all communicating with each other, coordinating care for treatment of that cancer, follow-up of that cancer, surveillance after the patient has beat the cancer. But in the end, there can sometimes be a diffusion of responsibility as to who really takes ownership of screening that patient for a hereditary syndrome. And oftentimes it gets left undone. And so really continuing efforts to increase awareness amongst our multidisciplinary providers who care for patients at risk for cancer and those with cancer is important. And thankfully, there have been systematic changes that have been implemented. But certainly as clinicians, it's important to keep in mind that any patient with early age onset cancer should be raising a red flag for a possible hereditary syndrome. That any patient with multiple cancers, whether it be at the same time or separated in time, should raise concern. As with any patient with a strong family history of cancer, especially if that's on one side of the family and any of those individuals are diagnosed young, but to really remember that the absence of family history doesn't rule out the possibility of a hereditary syndrome. There certainly have been kind of systematic pushes to improve detection of these patients. Large healthcare systems are now supported by multiple institutional guidelines and society guidelines, whether it be the NCCN, our pathology societies, our GI societies, to adopt universal tumor screening to improve recognition and detection of Lynch syndrome patients. And then, of course, continued efforts that once we identify Lynch syndrome patients, to march our way through the family tree and identify all individuals who may be at risk and assess those patients for presence of the mutation and identify mutation carriers within the family. Certainly, another very important area to focus on is continued efforts at initiating screening in patients at high risk based on their family history, based on their demographics. As we know, a family history of colon cancer significantly increases risk of colon cancer. And so our societies are in strong agreement that those who have a first-degree relative with colon cancer or multiple second-degree relatives should be screened earlier and potentially more intensively. There are many different tools available to primary care physicians, to kind of gatekeeper type specialties such as family medicine, OBGYN, to do a better job of not just acquiring family history, but incorporating it into decision-making such that that information is actionable. And I'd just like to highlight this resource in particular, this toolbox toolkit that was published by the NCCRT that really kind of goes through multiple different criteria for different family history tools, whether it be, whether the patient self-enters the information or whether it's an electronic questionnaire, a paper questionnaire, whether it needs to be customized to specific patient groups or languages, and the scope as to whether you want just an acquisition tool or really a decision-making tool, and has outlined all kind of existing tools out there. Such that practices can find a tool that works best for their particular clinical environment and not have to invent something or create something from scratch. What's really, really kind of, I think, an area that needs a lot more attention that specifically my colleagues in GI are focusing efforts on is that these guidelines that we've talked about focus not just on patients with a family history of colon cancer, but also advanced adenomas, or what we consider to be these precancerous colon polyps that are the immediate precursors to colon cancer. Of course, it's a great success in cancer prevention for us to be able to do colonoscopy and remove these and prevent a patient from developing colon cancer. But oftentimes the details of polyp history are lost, whether it be because we don't communicate them effectively to our patients, or whether patients fully sort of acknowledge and understand the gravity of their polyp findings. But we know that there's poor communication of these results to family members, and we certainly hypothesize and worry that a substantial proportion of patients who have family members with advanced adenomas are unaware of that and unaware that they should be screened earlier. And so just to really review, this is not a simple issue. This is something that I educate and review with my patients frequently. But, you know, a polyp is not all polyps are created the same. And so we know that there are different histologies of polyps, and certain polyps that we consider to be routinely precancerous, as well as others in the serrated polyp pathway that are precancerous, but then others such as hyperplastic polyps, which really don't carry any neoplastic potential. And so you can envision a situation where, for instance, a patient, a 44-year-old, presents to his primary care doctor, establishing care, thinking that it's about time that he get checked out because he recently went to a health fair where his labs showed an elevated cholesterol. And as you're acquiring and sort of thinking about his family history, he happens to mention that his 50-year-old brother just had a colonoscopy, and he thinks that his brother had a polyp. So what is the primary care doctor to do with that information? Because certainly the risk to this patient, this 44-year-old, is significantly different if we're talking about a small, polyp that this 50-year-old brother had versus really an advanced adenoma with focus of high-grade dysplasia that really is knocking on the door to becoming cancer. And so I think, there's a lot of work to be done in communicating specific polyp results much better to our patients, and then really emphasizing the importance of them communicating that to their family members so that these family members can be screened appropriately. We know that African Americans, certainly in early onset disease, but also in the general population, are kind of more likely, have a higher incidence of being diagnosed with colon cancer, and have a higher mortality associated with colon cancer. And so at least the Multi-Society Task Force has come to a consensus that these patients should be offered screening at the age of 45. What about just decreasing the screening age for all patients, regardless of ethnicity, regardless of family history, regardless of genetics? Well, that really segues into sort of the last portion of what I really wanted to talk about today, and that is to kind of frame the discussion in the context of our current guidelines. And so we know that the United States Preventive Services Task Force most recently updated their colorectal cancer screening guidelines in 2016. And although they acknowledged this rising incidence associated with colon cancer in young patients, really rested with beginning screening at the age of 50. Similarly, the NCCN, which updates guidelines annually, continues to recommend screening at the age of 50, as did the Multi-Society Task Force when they published their guidelines in 2017. In May of 2018, the American Cancer Society published a qualified recommendation to actually consider screening all individuals starting at the age of 45, in contrast to the age of 50, which has really historically been the accepted starting age. And so how did the American Cancer Society come up with this recommendation? So what they did really was use the same two reports that were commissioned by the USPSTF in 2016, and use the same sort of modeling approach, but updated the models to include the recent trends that we've been seeing in terms of the rising incidence and mortality associated with colon cancer in young patients. And what they tried to do was really incorporate the quality of evidence, so really this updated data on disease burden, the evidence that we have on the performance of screening tests, as well as modeling studies estimating the effects of screening, and balancing sort of desirable as well as undesirable effects and taking into account values and preferences. And so really what we learned from this effort by the American Cancer Society is that regardless of the screening test chosen, whether it be colonoscopy, CT colonography, fecal immunochemical testing, really stool DNA, or flexible sigmoidoscopy, that there were significant life years gained starting screening at age 45 compared to starting screening at age 50. Put in a different way, for every 1,000 patients who start screening over their lifetimes at 45 versus age 50, as expected, we are doing additional colonoscopies with starting at age 45. And of course, with the colonoscopy approach, that's about 810 additional colonoscopies compared to about the 300 range for stool-based testing. But across the board, there were 1 to 2 deaths averted in this cohort of 1,000 patients that were simulated, 2 to 3 fewer cases or decreased incidence of colorectal cancer, and about 25 to 26 life years gained. What about the cost associated with colon cancer? That's really colon cancer screening in patients under the age of 45. That's been one of the biggest sort of criticisms, that do we really have the ability, or is this approach cost effective to offer all individuals colon cancer screening earlier? Well, Yuri Lauterbach recently published this cost effectiveness analysis, which the results of which showed that starting colonoscopy at age 45 for all Americans would cost $33,900 per quality adjusted life year. Really, if we were to institute stool-based screening or fecal immunochemical testing at age 45 instead of colonoscopy, that would really cost us $7,700 per quality adjusted life year. Just to put all of that into context, when we look at a very well-accepted screening program, such as breast cancer screening, annual mammogram for patients between the age of 50 and 69 costs society $46,500 per quality adjusted life year. And so certainly, I think we acknowledge that there's a cost with suggesting screening earlier in the general population. But, relative to other well-established programs and screening approaches in our country, it does not seem out of the realm of acceptability in terms of really how we approach cost effectiveness. What about coverage? This is certainly becoming a very practical and salient issue of concern. What we know is that under the Affordable Care Act, any grade A recommendation made by the USPSTF is really kind of covered as a screening examination. However, not all states acknowledge the American Cancer Society guidelines within that same lane. And so, for instance, in Colorado, we rely upon the USPSTF guidelines to determine whether an exam would be covered as a screening exam, whereas there are these states highlighted in blue that accept not just the USPSTF guidelines, but also the ACS guidelines. So there's certainly work to be done to work with our stakeholders to emphasize the importance of screening and to broaden their acknowledgement of guidelines. There are certainly many questions that remain when we talk about this screening issue. Certainly the concerns that have been raised are that, the recommendations are based on modeling, not necessarily prospective randomized controlled trials, but that's really the case with all colon cancer screening guidelines thus far. There have been concerns that perhaps screening, or at least offering screening the general population earlier, may exacerbate existing disparities or strain our current resources or capacity. Though there's really not been a question as to whether we have, adequate colonoscopy capacity in the U.S. And then, of course, the continual concern over cost and insurance coverage. There are certainly areas ripe for research and future work and opportunities, really a nuanced approach to symptom evaluation in young patients, improving sort of the dissemination of the message that symptoms really need to be taken seriously, improving interventions to identify some of these high-risk patients, such as those with hereditary syndromes or family history. And then really just the bigger picture questions of why is this happening? And if we can understand the risk factors that are contributing to this rise in cancer in young patients, perhaps we can understand more effective interventions to prevent cancer. And then, of course, really the best approaches to screening and the work that we've discussed in terms of advocacy for support of earlier screening. So with that said, that really shouldn't distract us from focusing on the low-hanging fruit. So in parallel, as we talk about earlier screening for the general population, we should certainly continue our efforts to promptly evaluate symptoms, to recognize red flags for hereditary syndrome, screen those with a history of colon cancer, family history of colon cancer, advanced adenomas, and then of course, offer screening earlier in patients of African American ethnicity. And to not lose sight of really the reality on the ground, which is that even in patients between the ages of 50 to 75, those that are clearly eligible for screening under any guideline, we're still underperforming quite a bit, such that less than 70% of Coloradans who are eligible for screening in this age range are actually getting screening. Less than 30%, I apologize. So, certainly we need to do all of these things in parallel, and one does not need to be at the expense of the other, but to keep in mind that as we're talking about how to address the rise in early onset colon cancer, to make sure our efforts continue full steam to do better in screening patients between the ages of 50 to 75 as well. So with that, I'll pause and we can open up the floor to any questions, any discussion.
Thanks, Dr. Patel. That was very enlightening. We will open this up, as she mentioned, to questions. If you do have a question, please unmute yourself. Maybe state your name and ask your question. Dr. Patel so thoroughly explained the material that there's nothing to ask. Okay, I've got a couple, so I'll start it off. So I have a question on the hereditary and genetic screening that you had mentioned, and about the non-communication that happens among providers. So in your opinion, who should be doing the screening? And if it's not happening, how does the care team go about figuring that out?
That's a great question. Thanks, Ian. I think the ownership for who should be screened for patients really revolves around a system. So what I mean by that is that, as you saw, there's multiple different providers: the primary care doctor who sends the patient for their colonoscopy, the GI doctor who diagnoses the colon cancer, the pathologist who looks at the tissue under the microscope, the surgeon who's going to take that cancer out, and then maybe the oncologist who's focusing on treating the cancer. I think the best approach to improving identification of patients diagnosed with cancer who might have Lynch syndrome is to really implement systems rather than relying on any single individual provider along the way, because that really, if you do that, just puts you at risk for the priority being lost. And so really what I think a model for care is what we do here at the University of Colorado, and that is that every patient who's diagnosed with colon cancer really has a multidisciplinary visit where they meet with every specialist that they would possibly need in their care for their cancer, the traditional ones that we think about, but then also they meet with other providers that are important in their care, such as nutritionists, palliative care doctors, and palliative care specialists, but then also a genetic counselor. And so for every patient that comes through our doors that's been diagnosed with colon cancer, they get an immediate risk assessment. And I'll tell you, on the practical level, we certainly have patients who respond to that by saying, I don't care about the genetics right now. I've got to just figure out how to beat and treat this cancer. But the vast majority are extremely open to having that discussion. And we've just made it a systematic process in the care of all patients diagnosed with cancer, such that when they meet with all these specialists, one of those specialists is also a genetic counselor. And that really, I think, has improved the recognition of these patients, because at that point, the genetic counselor who's the most skilled at acquiring a family history, gets a detailed family history, and then is able to offer genetic counseling and perform genetic testing right there on the spot. The difficulties with, leaving a specific provider to make that referral is a fewfold, as we talked about. Certainly the oncologist or the GI doctor, their really focus for this patient is in treatment of the cancer. And really their kind of clinical approach to that patient is choosing the best chemotherapy, choosing the best surgical approach. And even if they do have the wherewithal to put in a referral to genetics, that patient has multiple sort of demands, multiple different sort of competing health demands. And to add the burden of another visit, another appointment, we know there's clear data that there's high no-show rates in this population. And so the other piece of it is that, there's established literature that patients oftentimes when they're battling cancer have a sense of futility. And so I think rather than putting one specific provider to be responsible for the screening, that it's better to kind of incorporate genetics as part of the systematic approach, such that every patient with cancer is evaluated by a genetic counselor, whether they need genetic testing or not. So that really focuses on patients who already have cancer. I think the much more challenging issue is, what about the patients who haven't developed cancer yet? At that point, that's sort of a patient that is interacting most intensely with their primary care doctor. And so, really the primary care doctor, along with the multitude of other responsibilities that they already have, I think the more we can do to support those primary care providers with tools, and so the NCCRT toolkit to really find tools that allow them to acquire family history in the most accurate and efficient way possible and actually act on it, is really a kind of a continued effort that we need to focus on. And then I think another kind of patient population that often times goes unrecognized are the patients that we see as gastroenterologists. And those are patients who are kind of coming in and out of our endoscopy lab that, I meet for the first time, right before I do their colonoscopy, and the opportunity that I have to acquire their family history, but then also make specific recommendations based on what I'm finding. And so it's really the gastroenterologist that's perfectly positioned to understand if a patient's polyp, for instance, is a high-risk polyp, and if that polyp is occurring at a younger age than we would expect, to start thinking about, is this somebody that could potentially have a hereditary syndrome?
Thank you. That was an extremely thorough answer. I appreciate it. I actually have a follow-up question on that. So I could be wrong about this, but I believe that capacity for genetic counselors is relatively low in Colorado. Is that true?
Yeah, and certainly my genetic counselor colleagues could speak much more to this issue. And I do see one of my genetic counselors here as an attendee, Michelle Springer. So please feel free to pipe in, because she will likely have a much more sophisticated response to that question. What I will say is that, you were right. There is a huge shortage of genetic counselors, and especially when we're talking about our communities in sort of more distant areas or frontier sort of communities. But what's really kind of an amazing evolving area of expertise in genetics is telephone genetic counseling, as well as sort of computer or web-based telephone counseling. And so that's really been something that has been a great resource, and something that the health systems that are utilizing are finding that as they build these resources, that more and more patients are willing to take advantage of it. But it's not an easy issue. There's certainly commercial companies that are genetic counseling companies that different practices, such as primary care practices or oncology practices, can partner with to provide those types of services more remotely. There are services that provide, language-specific genetic counseling, which is another, barrier that we often encounter. But you're right, there is a shortage of sort of in-person genetic counselors, but I'm optimistic that with some of the technology we have available to us, that remote genetic counseling will become, increasingly used over time.
Wow, okay. That's interesting. I did not know that that systems and providers were looking into the telehealth option for that, so that's great to know. Does anyone else have any questions? Come on, guys. Great opportunity here. Directly ask the subject matter expert here.
Hi, this is Laura. I have a question with regards to the African American population. If they want to start screening at 45, is that something that the insurance is going to cover for them?
That's a good question. Every insurance company is a little bit different. We have had success in getting our African American patients screened earlier. In some scenarios, it does require a letter of support to go to the insurance company. And in that letter, we have a form letter that just cites the U.S. Multi-Society Task Force guidelines. And at least from our experience, we haven't had significant pushback from that.
Thank you.
Of course.
Great question.
Swati?
Yes.
Hi, it's Michelle. Great presentation. Thank you.
Hi, Michelle. I'd love if you could speak towards the genetic counseling access question.
Oh, I thought you answered it beautifully. I do agree with you that I think, we all recognize that there is a shortage. As we are testing, all pancreatic patients across the board, possibly all breast cancer, all ovarian cancer, there are more patients who need genetic counseling and testing than there are counselors out there. But I think you're right. I think the whole idea of remote counseling, whether it's telephone-based counseling, a video platform, I think it is something that we will continue to see to grow. We know that some of the laboratories out there are developing these patient-initiated platforms where individuals can kind of go online and if they're thinking about genetic testing and genetic counseling, it'll kind of guide them through the process and give them options of meeting with someone locally in person or utilizing one of these remote services, telephone, telehealth approaches that would be available to them. So I think it's something that we all recognize and something that we are trying, we're trying to figure out how to meet the needs of these patients. I can tell you in the short time I've been doing telehealth, the patients seem to absolutely love it. Through, a video-based platform, you can share visual aids, you can share all of the same tools that you would in person. And you do also have that face-to-face connection. And so, I don't feel like the sessions have been any different than they would be in person. And, I think when we're talking about this patient population being individuals, many who have a current diagnosis of cancer, being able to do that in their own home, in the comfort and privacy of their own home, I think it's a big benefit to them, and I know they're very appreciative for the service. So I think it's an exciting, way that we're moving with genetic counseling. One question that I did have for you, Swati, you showed a lot of strong evidence as to, why earlier screening should be implemented, or at least that we should, really be thinking about this. Do you envision, the NCCN adopting these guidelines of, universal colonoscopy screening starting at the age of 45?
That's a good question. I mean, every year when the NCCN convenes, they are incorporating the newest evidence. And I think at this point, the evidence that we have is changing epidemiology. That's really not questioned, that there is a rise in incidence and mortality. I think what the NCCN and the USPSTF, really have been vocal about is wanting more definitive evidence on the best approach to screening. So whether that be colonoscopy versus stool-based testing, and then whether there are additional high-risk groups that would be better to focus on rather than kind of broadly recommending screening to all individuals at the age of 45. Because at this point, we really don't have, at least clinical evidence in terms of clinical trials that screening patients at an earlier age would decrease the burden of cancer because we don't know exactly which patients may show up for that earlier screening versus the ones that may not. And we also don't know kind of the best strategy, whether it be stool-based testing, colonoscopy, or some combination. We're starting to get more and more of that evidence. So this cost effectiveness analysis came out about a year after the ACS guidelines. So that's sort of new information that I think the NCCN will incorporate and weigh. And then certainly, the next time the USPSTF kind of addresses screening, that'll be taken into account. But I think, that's the hesitation. And so it's certainly clinically as a doctor on the ground taking care of patients, it's important for me to balance kind of what my clinical management of these patients is, and that is that this rise is real, that we're seeing this trend, and that we really need to do everything we can to address this rise and certainly focus on low-hanging fruit. But then the academic sort of hat that I wear and the research hat that I wear acknowledges that there's still big unanswered questions about the best way to screen these individuals. Now, with that said, the incidence of colon cancer in the average 45-year-old right now is about the same as the incidence of colon cancer for the average 50-year-old 20 years ago. So, when you think about disease burden, everybody was sort of in consensus to recommend screening at the age of 50. And so, it kind of is interesting that the bar for evidence seems to be, kind of higher than it was, 20 years ago when we really, started thinking about screening 50-year-olds.
Great,
Hi.
great insight. Excuse me. Oh, go ahead.
Hi, this is Gloria Rudolph. I have a question about screening in other countries. Do they recommend or start screening at an earlier age?
No, not that I'm aware of. And in fact, when it comes to screening, the U.S. has really been on kind of the more aggressive side of things. And so for context, Canada, for instance, they do have a screening program, but it's a stool-based screening program. And so screening is approached differently in different countries. In the US, we do kind of what's called opportunistic screening, meaning that patients who have access, show up to their primary care doctors and talk about screening get screened, whereas those who don't go to their doctors or don't have access don't get screened. In contrast, countries like Canada, the UK, it's more population-based screening, where everyone gets, essentially enrolled in a screening program. Not obviously everyone complies or participates, but it's not really dependent on a patient necessarily presenting for that discussion. And so in Canada, which is a stool-based screening program, they recommend screening at the age of 50. In a lot of European countries, Germany has a colonoscopy screening program, but again, with starting age of 50. The UK also is a stool-based screening program at this point, and they recommend 50. Now, what's interesting is that even though none of these countries have really adopted or recommended screening earlier, they're seeing similar rises in the incidence and mortality in cancers diagnosed under the age of 50 as well. So this is not a phenomenon that's unique to the United States. It's, when we think about some of those exposures that I talked about, these kind of very interesting hypotheses, we're seeing this rise similarly in other Western developed countries as well. And so it makes you wonder whether there's something about, our environment that is potentially contributing to this rise. And the curve is sort of shifted a little bit to the right for countries, more developing countries, where they're now more recently seeing a rise in early onset cancer. So not so much starting from the 70s, 80s, and 90s, but now really kind of in the 2000s that their curves are now inflecting up. And so perhaps, adoption of some of the more Western practices or diet might be contributing to that. But sorry, long-winded answer to your question, but no one else is screening in earlier age groups right now.
Thanks. These are great questions, guys. All right, we have about 5 minutes left, so time for maybe 1 or 2 more questions. I have another one. I'm kind of stuck on this communication piece. And it seems like one of the more important components is for the patients themselves to know their history, and as you alluded to, like more specifics, not just I got screened and I had a polyp, but that can be confusing. So how do providers how can they do a better job of explaining the importance of them knowing, and then how to talk about that with their provider and their family member, or their primary care provider and their family members?
That's a great question, Ian. And something that I've actually been intimately sort of challenged with and working on. I think, if I were to focus on, for instance, the group of patients that have these advanced polyps, what's challenging is that, we don't know the patient's going to have the polyp until we do the colonoscopy. Then we sedate them and make them very loopy and forgetful. And so even any direct communication that the doctor may have with the patient after the procedure is under sort of a compromised circumstance for the patient to actually sort of internalize and understand that. And so my belief is that we really need to make this more systematic, that any patient diagnosed with an advanced polyp should have a very kind of specific kind of set of information conveyed to them in both written and electronic form, and with specific actionable sort of to-do items based on that information. And so what I mean by that is, we've developed essentially an infographic which describes in general the pathogenesis of colon cancer from normal tissue to small polyp, large polyp to cancer, just to kind of explain the basic biology of how colon cancer develops, and then to highlight for the patients who have advanced colon polyps where their polyp was on that spectrum. So that educational piece sort of in lay language, in written form, as well as electronic form, that we release to any patient who has an advanced colon polyp. But then on the end of that infographic is that really a clear explanation to the patient that this not only increases their personal risk of developing another advanced precancer polyp or a cancer, thus necessitating kind of more intense surveillance, but that this increases risk of colon cancer and colon polyps in their family members, and that we recommend sharing this information with their family members. And so in addition to the infographic, a link to resources and further explanation that then these individuals can share and forward to their family members. And so these are sort of pilot tools that we've developed here at our institution. But like with anything where we're trying to implement a change in clinical practice, it takes time. And so we've now sort of created customized phrases that once an endoscopist, and we have 30 people who do colonoscopies here at the University of Colorado, diagnose one of these polyps or get back the pathology which confirms one of these polyps, a very simple way for them to just put in kind of a what we call a dot phrase in our electronic medical record system that sends all of this to the patient. Now, can we say that this has been effective in improving awareness amongst our patients or their family members? That's a little bit harder to track and tell. We actually tried to get a grant funded to assess the effectiveness of this tool but we're met with challenges because, with research, the patient in front of us is the patient that we can consent to participate. And so it's very, very challenging to find out, whether this information actually made it to their family members. And then really the most important outcome of, did those family members get screened the way they were supposed to? So still a challenge to kind of know exactly what the impact of something like this would be, but an important start. And really, the other resources that are available out there, the NCCRT has a nice toolkit on advanced adenomas as well. And so there's a lot of infographics and educational tools, and those tools are mostly geared towards providers. And so the unique piece that our infographic adds is that it's really customized for patient communication and family communication.
Great, thank you. All right, Dr. Patel, thank you so much for your time and this great information that you presented to us today, and thanks all for attending and your participation. With that, we will wrap it up. Thanks so much for joining, and we'll talk to you soon.
Great, thanks, Ian.
Thank you.